Hi, everyone. Welcome. I'm going to give it another minute or so to let folks join us. I hope everyone's having a wonderful day. At least in the DC area, rain has kind of subsided, a little gray, but still warmer than what we had. So I'm grateful for that. We have a good contingent joining us. And just as a reminder, this is recorded for the purposes of just internal AHRQ folks, so they can come, people who couldn't attend this session can come back and click on it. And we've been sending out the links over email, and I hope you've had a chance, if you weren't able to get to some of our previous sessions, to watch. They've been really great discussions, and we've heard some really great feedback from folks about really liking this format. And today we're really excited because David couldn't join us today, but we are really excited to have Dr. Bierman here with us to help lead us through this discussion with Dr. Sinsky on clinician burnout. Before we do that, I just want to make sure that folks know that your calendar is marked for Friday, March 25th from 11 to 12 for our next director series conversations, which is a discussion with Arsenio Mataka, who serves as the Senior Advisor for Climate and Health Equity to the Assistant Secretary for Health. So we look forward to that discussion. But for today, we are grateful to be joined by Dr. Sinsky. As a reminder, please I'll let you know in the chat, but please put any questions in the chat to us, because we really look forward to this engaging conversation. And with that, I'm going to turn it over to Arlene to kind of kick us off.
Yeah, so I'm very much looking forward to our discussion today, and really give a warm welcome to Dr. Christine Sinsky. And although she probably needs no introduction to most of you, she is the Vice President of Professional Satisfaction at the American Medical Association. She's a board certified internist, and she practiced at Medical Associates Clinic in Dubuque, Iowa for 32 years. She's also a member of the Board of Trustees of the ABIM Foundation and was its chair from 2018 to 2020. She has worked to improve opportunities for joy, purpose, and meaning in work, and has publications on the quadruple aim, joy in practice, texting while doctoring, and creating a manageable cockpit for clinicians. These have all contributed to the national conversation in so many different ways. She has also contributed to research regarding the prevalence, drivers, and solutions to burnout among physicians. So I'm going to turn it over to Dr. Sinsky, who's going to give us a brief overview of her work.
Great, thanks, Arlene. It's a pleasure to be with you today, and I'm happy to be talking about creating resilient organizations and how it's a shared responsibility. And I hope that that stimulates questions and conversations and thoughts about AHRQ's role in this. And I have so much high regard for AHRQ's contributions so far to addressing some of these issues. So very grateful to the work that you all collectively are doing. I want to ground our thinking around professional well-being and its inverse burnout with this notion that while burnout manifests in individuals, it originates in systems. And so when we think about addressing burnout and reducing burnout, we need to think about systems approaches and fixing the workplace rather than thinking about fixing the worker. To emphasize that, this is a study that we published in 2020 that shows that resiliency is not the problem. Physicians don't have a resiliency deficit. In fact, in this study of over 6,000 physicians, we found that resilience among physicians was quite a bit higher than the general population. Again, emphasizing it's a systems problem, and so the solutions will need to be at the systems level. If you look here, there were different resiliency scores for the population of physicians that were surveyed. And even those who were in the highest resiliency, who had a score here at 8, 30% of the physicians in this survey at the highest level of resilience still had burnout. So it's a very high rate of burnout, even among the most resilient physicians. And then among this population, this profession that is more resilient than the general population. So, and why do we care about burnout? I think you all know this, but I want to just give you a couple of highlights. We care about burnout because it impacts our patients. When we're burned out as physicians, we're twice as likely to make mistakes. Our patients are less satisfied with our care. One study indicated that there's twice as many patient complaints that are registered regarding physicians who happen to be burned out compared to those who are not. We care about it at the physician level because our colleagues are suffering when they're experiencing burnout, and there are higher rates of adverse outcomes, including divorce and death among physicians who are burned out. And then organizations need to care about this. At a single health system or healthcare organization, there are costs, higher malpractice costs. Physicians are more likely to turn over. In fact, longitudinal studies from several different organizations have found the same result, and that is physicians who are burned out at time X are twice as likely to have left the organization 2 years later. And that turnover is very expensive. It's been estimated that it costs $500,000 to $1.3 million to replace each physician who leaves. At the organizational level, we've done some studies, and we have a calculator so organizations can put in their number of physicians and their rates of burnout and find out what the cost that they're expending every year on burnout is. They're just expending it at the far end of replacement rather than investing a small portion of that up front to reduce burnout. So if you're an organization of 1,000 physicians, we can estimate that you're already spending over $10 million a year on burnout. You're spending it replacing physicians who leave the organization. So that's at the health, individual health system level, but at the wider US health system level, we have estimated and published using very, very conservative estimates and data from the literature that the US healthcare system itself is spending $4.6 billion a year on burnout, just on the replacement of physicians who leave. And then most recently, we just published a study showing that payers, commercial payers, public payers, and patients experience an excess of 260, that should be $1 million every year of excess healthcare expenditures related to having lost their primary care physician related to burnout. So when we think about well-being, professional fulfillment, or its inverse, burnout, I think it's really helpful to use the lens of this model that was developed by the Stanford WellMD Center, looking at the drivers of well-being or of burnout being organizational culture, practice efficiency, and then individual resilience. And I like to consider that last category really as institutional support for individual resilience. So in some of the things that we would consider as targets for both research under organizational culture and targets for intervention, leadership. We know that the leadership score of a physician's immediate supervisor is responsible for about half of the variation in their work-life satisfaction. Connectedness, trust, control, meaning in work, peer support, respect. Practice efficiency, I think this is the area most fruitful for further research because there's so much waste in the healthcare system in terms of workflow. And so in practice efficiency, it's looking at team structure and function, taming the EHR, taming the inbox, and using EHR audit log data as one way to understand and characterize the current work environment and then using those audit log data metrics to identify whether the intervention had a positive effect on things like pajama time, which we call work outside of work, or WOW. And then in the personal resilience, there are issues around self-compassion. We recently published a study showing how directly related our ability to be compassionate with ourselves connects to burnout and self-care. And also, I think we need to think about the medical culture that physicians have adopted through our training and practice, the Iron Doc model that we have developed. So I'm going to speak briefly about the great work transfer. I spent 32 years in practice, as Arlene mentioned, 16 of them before the EHR. Much of that I was anticipating, oh, how great it will be when we have a computer that will automatically pull in all the meds and do all this wonderful thing, all these wonderful things for us. And then the second 16 years was with EHRs. And I spent much of that time realizing how big the gap was between the promise and the reality of the electronic health record. I found that the EHR both created more work. It took longer to do the same work for many of the tasks, but most importantly, it transferred work. So we've talked about the Great Resignation, but I think if we look back 10 to 15 years, there was a great work transfer that happened, and we are still feeling the impact of that. We haven't accommodated to it. We haven't fully recognized it. So in my own life, work that previously had been done by the receptionist, the pharmacist, the transcriptionist, the medical records clerk, many other workers within healthcare became now the responsibility and the work domain of the physician when the EHR was implemented. And that led to time pressure, 2 hours on the EHR for every 1 hour of direct face-to-face time, lots of pajama time. And I think another area under-recognized is that it's actually really contributed to cognitive overload, making it harder to do the same work, taking a lot more mental energy to synthesize information that's coming from very disparate places within the EHR. I'm going to focus a little bit on the inbox because I think that's relevant to 2022. It's often said that people don't leave their jobs, they leave their bosses. And I would propose that for physicians, physicians aren't leaving their profession, they are leaving their inbox. This was becoming an increasingly big problem prior to the pandemic, where data showed that physicians are spending on average 1.5 hours on their inbox per day, family physicians. We also know pre-pandemic that inbox volume was a driver of burnout, that those in the top quartile for inbox messages per week had an odds ratio of 6 of burnout compared to those in the lowest quartile. And you'll see the top quartile was 300 messages a week. The average primary care physician has 100 email messages a day. So you can see that this is a driver of burnout, particularly for those who are in the primary care specialties. Likewise, work outside of work or pajama time, very strong driver of burnout with an odds ratio of 13 between the top and the bottom quartile. That was all pre-pandemic. What's happened with the pandemic? This is work that uses EHR audit log data, looked at Epic's entire US user base, and found that at the onset of the pandemic, the number of inbox messages that were patient advice requests, which is a component of the inbox volume, went up by 157%. And it has stayed up through the course of the pandemic, and there's no indication that that's decreasing. So there's so much that practices can do. We call these the practice fundamentals, and we believe that when physicians, when practice managers, when teams re-engineer the work that they do, eliminating wasteful work, what I call sludge, all the sludge that's clogging up the gears, and then more strategically delegate work to an upskilled and stronger, larger team of clinical support staff, medical assistants or nurses, that physicians can save 3 to 5 hours a day across various specialties and across various settings. And so here are some of the practice fundamentals, and they're all ripe, I think, for both research and for implementation. On the implementation side of the AMA, we've created over 70 how-to practical toolkits on how to do some of the practice fundamentals for the patient practice efficiency, and how to do some of the leadership and other organizational culture changes that will lead to greater professional well-being, which will lead to patients receiving care from physicians and teams who find joy in their work. So now we've collected some of those toolkits into a saving time playbook. We also have a series of podcasts where you can listen to the authors being interviewed by one of our physicians and hear about the innovation directly from the author through a podcast. We also have webinar series that are available as part of this. And then lastly, I wanted to share with you the Joy in Medicine Health System Recognition Program that we've developed at the AMA. And we developed it for 2 reasons. One was to recognize vanguard organizations that were leading the way in terms of building systems that created resilient organizations that protected and supported the individual people within. But we also did it, and this would actually be its primary purpose, to provide a strategic roadmap for organizational leaders who say, I know we need to do something about this big problem of burnout among our workforce, but where do we start? What do we do? Well, this provides that kind of roadmap and has been used in that regard by many, many organizations now. But it also can be, I think, a guide for the research agenda around burnout. And so you can see that we have 3 levels of achievement, and most importantly, 6 different domains of activity that an organization can do activity within. And one of the areas that we've been talking about today is efficiency of practice. And you can see that we have, these are just high level, we have more detailed specifications, but we have requirements at the bronze level to measure work outside of work using that audit log data, at the silver level to share it with the leadership, at the gold level to implement interventions and use the audit log data to identify whether your interventions have made a positive difference. So we're going to end where we started, and that is with this takeaway message that while burnout manifests in individuals, it originates in systems. And so I think it's so important that our research and that our interventions really begin with that understanding and focus our efforts at the systems level. And with that, I'm going to stop sharing my screen and look forward to our conversation first with Arlene and then with all. So thanks so much for that. Let me see if I can make that go.
Dr. Sinsky, thanks. That was amazing. I mean, you just summarized so much literature in very succinctly, and it's such important work. So thank you for your work and your leadership in this area as well. I think you really set the framework for our discussion and really highlighted, this has been a chronic problem, and it's gotten even worse with the pandemic. And I was wondering if we could just step back for a minute and tell us, how did you get interested in this and kind of the trajectory of your work in this space?
Sure. I'm happy to. So I think part of what got me interested in this was, I have to be honest, motherhood. And so having young children, being a physician, I didn't have time to waste. And yet I had this mission that was so strong of trying to optimize the care we gave. So over time, did a lot of continual refinements in my practice to improve practice efficiency. When I was able to kind of raise my head and look up and connect with others through the Society of General Internal Medicine, I realized that the practice fundamentals that we had come to were not widely implemented elsewhere. And as I started to then go around the country and shadow physicians doing their work and give grand rounds at various organizations, I started to mainline the angst and distress that my colleagues were facing because they knew they were spending their days doing the wrong work for patients. And so I think, Arlene, part of how I got into it was I realized how much suffering our colleagues were experiencing, and that suffering had to translate into what patients were experiencing, and that it's a fixable problem, that it's not in, we have such inherently meaningful work as physicians. And so to get back to the joy, purpose, and meaning in work, I think it's both important and feasible. And so I think that that's a part of how I came to that. So thanks for asking.
No, that's great. And it's interesting. So I'm a geriatrician, practiced for many years, the most complex people. And I estimated, just in terms of gathering information, what happened to them when they saw consultants, when they were seen in another institution, and then talking with family, caregivers, figuring out the pharmacy. I estimated that for every hour I spent in clinic, I spent another hour trying to do the care coordination. And, our digital health, division does a lot of work on EHRs. And I know that some of the work you've done has focused on that, and especially really interesting the work on, log audit data. But can you talk a little bit about how EHRs can both exacerbate and ways they might be able to mitigate some of these challenges?
Yeah, I'll be happy to, because as I said, I spent so long anticipating the arrival of the EHR and then so long thinking about why did it not actually live up to its promise. And I think in some ways, just to do the personal lens on this, it did make me a better doctor in some way. Having the computer in the room, being able to access up to date, that was helpful. Being in the hospital and in the patient's exam room and being able to pull up what happened in the clinic, that was helpful. No longer having to see a patient without their record was helpful. But in so many other ways, it made it harder to be the doctor I had been before. And it made it harder to be the doctor that I wanted to be. And so I think there's a couple things that really contributed to that. I think part of it's the design of the EHR. It wasn't designed with a lot of human factors understanding. So we don't have process coupling. We don't have clear, concise display of just the key information. There's a lot of clutter of other stuff there. And then we have a lot of siloed information. So the cognitive workload in terms of how the EHR was designed could be so much better. But so much of why there's this gap between promise and reality for the EHR, I think it's how it was implemented and how it was regulated. And I think that's where we really fell short. And I think so much of meaningful use was well-intended, but it was fundamentally flawed in thinking that something was always safer if the doctor was made to do it. And I think that that's part of the superhuman myth that people have about physicians. And it isn't safer if the doctor does it. The idea that we can't have verbal orders is honestly, it's crazy. And it creates so much sludge and so many barriers to doing care. It made sense around a conference table, but it does not make sense in the actual day-to-day work. I think also we have impoverished primary care, and we have underfunded most ambulatory non-procedural work. In my own practice, we had 2.5 RNs per physician. That led to a really high level of care that we could give our patients. And our nurses stayed in the practice for a very long time. So my last nurse that I had as my primary nurse, she and I worked together for over 20 years. She knew the patients, I knew her, she knew me. All of that was really, really important. But if you build the model on a half of a medical assistant per physician, you just never get that kind of teamwork to wrap around this information system of the EHR. And so I think how it was designed, but how it's been implemented, how it's been regulated, has really led to, it's been harmful to primary care.
And so what could we do about it now that this is a current situation? Do you have any suggestions for moving forward?
Well, I do. I think there's a couple things. I think undivided attention is our superpower as healthcare professionals. And I really do believe if we had an Uber measure that we extracted from the EHR on undivided attention, and we have a way of doing that using EHR audit log data, and we incented organizations to optimize the amount of undivided attention their physicians can give their patients, that we would actually lead to better outcomes. Now, organizations can do that however they like, but one way would be to provide a stronger team, such as I had in my practice of 2 or more nurses or medical assistants per physicians. And the other thing I think we should really understand is that our work as physicians, as healers, is fundamentally about relationships. And the EHR has caused us to build systems and think that healthcare is all transactional. And it forces us into a very transactional mindset. And I think that we need to step away from that transactional mindset and look at how is every decision that we're making, whether it's around our technology or around other aspects of care, how is that strengthening or undermining relationships? And I don't mean this in a fluffy way. I don't mean it in a just like feel good way, and I certainly don't mean it in a turn the computer screen so the patient can watch you type way. I mean it in that I am a better diagnostician when I know the patient. The patient is more likely to adhere to my treatment recommendations if they know that I care about them. And there are so many ways you can structure the practice environment so that you know the patient. I had my nurses give me a mini huddle between every patient. Tell me something medical and something social about the patient before I walk in the room. So I know if a family member just died, I don't run in there cheerful. I kept social notes about the patients. We would have patients bring pictures in about things that were important to them in their life. And all of that made me more efficient, made me a better diagnostician, made me order fewer tests, and I believe made the patient come to see me when they really needed to see me, rather than going to the ER or waiting till a problem became accelerated and more expensive and more damaging long-term. So those are sort of meta concepts, if you will, but I just think undivided attention is our superpower, and our other superpower, particularly in primary care, is relationship.
Yeah, no, that's really, true and interesting. At AHRQ, we developed what we called the care and learn model, which tried to emphasize that caring is really the heart of what we do in medicine. And then the learning is, the data-driven evidence, synthesis, implementation. We need to do that too, but they're two different worlds and they haven't come together. And we're really struggling with how do we, get the evidence on how do you, move systems to bring these two parts of healthcare delivery together. So yeah, but I guess what I want to ask you, and I really liked what you said about, sort of it's the burnout is a manifestation of the system and the person, that you have values, you have standards, and feeling like you can't do what you were trained to do, or that it's really frustrating. And that relationship piece is such a key part of medicine, of knowing your patients, and that helps you do the right diagnosis. You know what's going on. So, and I really liked when you showed, what you've developed at the AMA in terms of certifying organizations, in terms of their support, for clinicians and to reduce burnout. Can you talk a little bit more about systems level interventions and what it would take to scale and spread those more widely? Because it's really culture change that we're talking about in healthcare delivery, which is hard.
Right. And I think it all does relate to what you were talking about the caring. And that I think what's happened is the mandatory but unimportant has pushed the caring to the margins, because it's easier to measure the mandatory kind of process things. And so those are what we measure, and that's what we build systems around. So I like to think about production line work and solution shop work. And production line work is the standard predictable work of the practice. And solution shop work is the diagnosis and management of unstructured problems. And we have diverted, I would say, in primary care, 75% of our attention to production line work. And we have crowded out the space for solution shop work, or for the caring, not just emotional caring, but the caring that comes from actually making good diagnosis and making good therapeutic recommendations. So there are many things organizations can do. Some of them are operational. Health Partners in Minneapolis established flow stations where physicians and their medical assistants sit side by side. They save 30 minutes a day by doing that. Putting a printer in every room saves Health Partners 20 minutes a day. Having large monitors so that you can see a big swath of information saves 20 minutes a day. So right there, you've saved an hour of time a day. And again, by doing more of those, you can save up to 3 to 5 hours. Give an hour of that back to seeing patients in a more relaxed way. Give an hour of it back to the physician's personal life, and give an hour of it to further improving systems. So those are a few things. There are many more. Just having the University of, Intermountain found that by going to a 2.5 MA per physician role, they were able to decrease the amount of documentation time by 20%. They could increase the number of patients seen, so there was more access by 20%, and their burnout dropped by 50%. So that finding ways to strengthen the core team, the physician and that team, are other ways that we can improve the practice and therefore reduce burnout and improve the patient experience. And happy to talk about more, but that's the tip of the iceberg of some of the things that organizations have been doing.
No, it's great. And it's sort of, how do we capture that innovation? I guess your workbook, and the tools that you've developed is one way of doing that. I want to ask you a little bit more about research in this area, but before I do that, I want to get back to the balance between individual and system level interventions. And you mentioned that systems really need to support staff to be resilient. And
yes.
Interestingly, AHRQ did a learning community for primary care practices in response to the pandemic. And it was shocking. They could have been part of the solution, and instead they were, neglected, not given resources, even, protective equipment. I mean, it's really sad how primary care was, and, many shuttered their doors, but others used the opportunity to be really, really innovative. And we did a wonderful dialogue around burnout and, in the face of COVID. And, the first thing people said is, don't tell us to do yoga. So could you tell us the balance between supporting the self-care and the resiliency and the institutional support to individuals?
Yeah. So I love that. Don't tell us to do yoga. And I would encourage anyone who's interested to read an article called Muffin Rage in the LA Times. And it's written by one of our colleagues from Canada. And she talks about the rage that people feel when the solution that's offered to a healthcare workforce under stress is muffins and, and a soda or something like that. And I think it's so important for health system leaders, even if they want to show appreciation with something like, a treat, you cannot lead with that. If that is the sum total of what you're doing, it's really harmful. I'm thinking about a conversation I had with Carrie Palomera, who is a physician at Mass General Hospital in Boston, and she leads their well-being work within the Department of Medicine. She also led their respiratory clinic that they started at the beginning of the pandemic, and they were pretty hard hit. And she told me in that she said our physicians went from hating their EHR to finding it incredibly helpful in a matter of days. I said, Carrie, what did you do? What changed? And she said, verbal orders became the norm. We entrusted medication reconciliation to the RNs and the MAs, and we created crisis standards for billing so that billing was simplified. Now, this was in 2020, so it was before the really wonderful changes that CMS made in terms of E&M coding changes in 2021. But I think that the learning there was, again, to remove the sludge and to remove the production line work away from the physicians and give them the space for the high level caring and critical thinking that needs to happen in caring for complex geriatric patients, complex COVID patients. So those are some things that I've seen that not only remove the pebbles in the shoe, but really de-implement things that no longer make sense. And I will tell you, we have a de-implementation checklist that we have created. We had the Joint Commission review it. They generously reviewed it, so we modified to their review suggestions. So we know that the things we're recommending that organizations consider de-implementing are kosher with the Joint Commission and therefore with CMS. And so we have published those, and we include those as one of the criteria in the Joy in Medicine program, but you can access those even if you're not participating in that initiative.
Oh, no, that's great. I'm so glad, to hear that. So, and in sort of segueing into research, just so you know, AHRQ released a special emphasis notice on primary care research. So get the word out. Yes, to everybody, but one of the things we've highlighted in there was research on de-implementation. So it's definitely on our radar screen. So my question for you is, as AHRQ, we try to, value-based care, we try to do value-based research, given our limited resources, what would you suggest for us is like, what are the levers? How can we support research to really advance this work?
Yeah, so first of all, great. I'm so glad that you are doing that and you have a focus on implementation. I think you're meaning implementation of research or implementation of EHRs?
No, de-implementation of unnecessary. So no, we're interested in both, but we really called out de-implementation as a special area of stop it doing things that we don't need to do, right?
Okay, I love it. And of course, you're getting close to getting rid of stupid stuff, which was also a wonderful article that Melinda Ashton wrote for the New England Journal of Medicine. She has subsequently done Steps Forward toolkit for us, giving a step-by-step approach to how an organization can implement their own getting rid of stupid stuff or de-implementation initiative. And she's also done a podcast and a webinar. So we've got a lot of resources that can be used. I love the idea that you are funding this. I think that the research around audit log data is in its infancy, but it has grown in the last 4 years. And I recently heard from one of the other researchers in this area that they did a literature count, and there was a dramatic increase in the number of published articles using EHR audit log data. And I'll just tell you, we've sponsored now 13 pilot studies using audit log data. And I'm in the process now with our review team of looking at, we have 12 applications for 2022, and we will fund probably 8 of them. And they are looking at the inbox, and they are looking at ways to decrease the burden of the inbox. They are looking at the other connections between audit log data and career plans, and a variety of other aspects that you can assess, implement changes, and assess again using the audit log data. Happy to go into that more, but it's just a field I think that's so ripe for further investment and even more sophisticated studies than the pilot studies that we're doing.
So I see Jamie is on. We have an active chat, but before we turn it over to the questions, I just have one question for you. Is there anything else that you hope to talk about that you haven't had a chance that you'd like to bring up before we go to the Q&A?
Well, I think I might just tell you about one other tool that we've developed at the AMA. We have a data lab that I referenced that we bring in our mini Z results for. And we also brought in our Coping with COVID survey. We had 75,000 respondents to our Coping with COVID survey that we did through over 100 healthcare systems. We now have an organizational biopsy, which is about 70-item instrument assessing the 4 domains: the organizational culture, practice efficiency, individual self-care, and then work intentions. And we've done the psychometrics on that. We have subscales within each, and we do all of that at no cost to organizations to do that organizational biopsy. And our vision is that it will be useful to the individual organizations to get that kind of deep insight from pulling back the curtain to understand what's happening in their organization in those domains. And that in aggregate, that will serve as a research bed to understand the interrelationship between organizational culture elements of trust, connectedness, control, meaning, practice efficiency, and professional fulfillment. And my hope is then some of the early studies coming out of that can be seed studies for larger studies that AHRQ and others will fund. So that might be one last note to share.
Fantastic. This has been great. And I'll say we've had an active chat and lots of people posting comments and questions as well. So I'll start with one only because I think this is important, but can you elaborate on the influence of organizational culture on burnout? As you know, AHRQ produces survey on patient safety culture. And so just curious what your perspective is on that.
Yes. So I do really agree with the Stanford model. And I often will say it's my observation that about 80% of burnout is related to systems factors and only 20% related to individual factors. And that probably half of that is related to organizational culture. And so I think one of in organizational culture is made up of many things, but one very tangible thing is, I think the more we push decision authority closest to the physicians and others who are closest to the patient, the better the outcomes. So I think that's one dimension of organizational culture that maybe needs a little bit of bringing to the light of day. We've had a decade or more of standard work and making everything the same and sort of centralizing control. And I think that that standardization needs to be balanced with a recognition of the importance of being able to customize the care at the point of care. And to do that, you need to have some decision authority that is intentionally directed toward those people who are closest to the patient.
Great. So there's been a couple of discussions back and forth when you had said, you know, the EHR didn't work well, and some comments were, yes, it did, because it was designed to improve billing, and so it didn't do that well. And so, so the question is then, you know, how can we get EHRs to change and serve clinicians and be better for patients?
Right, right. And again, I find it helpful to think about the pain points of EHRs coming from design, implementation, and regulation. And so there's activity at the design level, implementation, and regulation levels. I think by having more data about how much actual time physicians are spending during their family and personal time on the EHR will create a pressure to change the design, to change the implementation, and to change the regulation. I think the more research we do on cognitive workload and how different displays of information can actually add to the error versus reduce error are helpful. So I'd love to see simulation centers where the same clinical scenario is given to physicians and the display is either how it currently is, very cluttered with a lot of non-essential information, causing a lot of fragmentation of thought, causing a lot of mental interruption when you go from screen to screen, and then have an optimized display, take those same scenarios through and measure the efficiency, how long did it take to gain situational awareness, and the safety. What were the decisions in that scenario that the physicians made that were appropriate, and what were the ones that were not? And I would guess that we would find that safety and efficiency are really highly dependent on how that information is displayed. In my own practice, the EHRs listed medications in alphabetical order. Well, that has no value in medical thinking. If you group them by organ system, you can more quickly digest the information. In my EHR, the name of the medication was repeated 6 times. The generic with all the chemical pieces, and then the trade name, and then the generic, then the trade name again in the med display. So the medication display went over 3 pages. So you couldn't look at the whole of the patient's medications in one visual screen. That's a safety hazard. And if you care about safety, you have to care about the cognitive load. And if you care about safety, you have to care about well-being as well.
Okay, another question. Are you able to track who uses your Steps Forward curricula and what impact they have?
I love that question. We can answer half of that, but not the other half, but intentionally by design. So we have had over 1.3 million unique users of the Steps Forward toolkits in the 5 or 6 years that they've been available. We make them open access to everyone. You don't need a username, you don't need a password, you don't need to be an AMA member, you don't need to be a physician. We want as many people to have access to these as possible. And so we don't have a registration and a tracking function about them. What we do have is plenty of anecdotal feedback that keeps us going, that people who heard one of my colleagues at the AMA, Dr. Marie Brown, as an example, spoke to an FQHC. They got interested in a more efficient approach to prescription management, which she had articulated and about which we have a lot of detailed guidance and Steps Forward. And they, after a year, had been able to save an hour of physician time per day by having improved the way they dealt with the prescription renewal process.
Great. So you talked about, you alluded to this in one of your examples that you described, but the question was, would task delegation using system approach and teamwork help reduce physician burnout due to an increase in inbox volume and EHR demands? But I wondered if you could talk a little bit more about the teamwork approach and what the AMA is doing, or view on that.
Yep, absolutely. So I will first tell you that I think that a stronger core team, the team of the physician or APP and their nurses or MAs, that core team, strengthening that, I call it TSSS. So it's team structure, skill level, and stability. So if you have team structure, you go from a half of an MA to 2 MAs or nurses. Stability, that you make the work meaningful for those team members so that they don't turn over every 8 to 12 months, but actually stay in that role. And then they're upskilled. Then all of that increases the capacity of the organization, of the team. You can see more patients. You can make access, same-day access, a reality for your patients, and you have less burnout. And there was recently a study that came out of, that was in the Annals of Family Medicine. It came out of North Shore in Chicago. And they looked at one dimension of TSSS, and that was the stability. And they found that without increasing the number of staff, but simply by intentionally pairing the same medical assistant with the same physician, they had 11% more capacity. They generated 11% more RVUs, which meant that they had more capacity. And I think this idea that people are interchangeable widgets, it's all in the EHR, is really, again, harmful, because not all knowledge is housed within the EHR. A lot of knowledge is housed in the relationships between the patient and the physician, between the patient and the nursing staff, between the nursing staff and each other, between the patient and the physician and the nurse. So the more we prioritize relationships and stability of those relationships and the skill level within, and just the number of people who are on a core team, I think the better our outcomes will be.
I think we got through most of the comments and questions. I don't know if you have anything else you want to add, Arlene.
No, first I just want to qualify my comment about yoga. I'm a big believer in yoga. I wasn't trying to disparage it. I do it myself. I just don't think it's the solution for clinician burnout. So I don't want anybody to take my remarks off out of context. But actually, Christine, so I have a couple of last questions for you. Who else should we be listening to, learning from, and partnering with as an agency?
Yeah, so that's such a good question too. And first, I'll also have my own disclaimer that I really think we need to focus on system things, but I am a big believer in self-care, in making sure that we do exercise, eat well, get plenty of refreshment. And as an aside to that, one thing we haven't talked about was we put as a measure within the National Burnout Survey that we do every 3 years with Stanford and Mayo. We also put it in the organizational biopsy, an instrument on vacation. And do you take vacation? And does your organization encourage you to take vacation? And there's a lot of perverse things happening within organizations that I think unintentionally prohibits physicians from taking vacation. And so to have structures in place within the organization that ensure that people do actually take their vacation and don't do their inbox while they're on vacation, I think is important. But who else? So I know that you know that some of the leaders in the field include Stanford and Mayo. Stanford has the Professional Wellbeing Academic Collaborative, which is a group of well-being professionals, generally chief wellness officers, many of whom have gone through Stanford's Chief Wellness Officer course. I'm fortunate to be one of the faculty of that, and we've had 3 cohorts of chief wellness officers go through that. These are committed individuals who understand the drivers and consequences of burnout and are actively working in their spheres of influence to create better organizational culture and practice efficiency. So I think they would be excellent individuals. So that the PWAC consortium, there's also the CHARM consortium, and that's a network of chief wellness officers that's organized by Jonathan Ripp at Mount Sinai in New York. And then for those who are interested in the audit log data, Julia Adler-Milstein at UCSF has established the National Research Network using audit log data. And I think we have about 80 members. It's all voluntary. Anyone can join. And once a month, someone presents research that may be in progress. And they get a lot of feedback from others who are on the call, questions about, did you consider this? Did you think about doing it this way? Or that relates to this. So that's a network that anyone interested in understanding more about what's happening in that realm of research can join and listen in on those calls or listen to the recorded calls.
And so just in closing, can you recommend some resources for AHRQ staff who want to learn more about this area? You already had a number of them in your slides, but are there any that you want to add?
Well, I think I might just reiterate that we have the Steps Forward, we call it the Steps Forward Innovation Academy, and within that are these 70 how-to toolkits, but we also have the webinars and the podcasts. We have the we have the de-implementation checklist that you know about, the Joy in Medicine recognition program. We also have a debunking regulatory myths page. So if you Google that, you will see myths that we understand are common in the environment. We have gone and done the research and found the place within the Federal Register or within Joint Commission to debunk those myths. So those are available. And then I would also point people to the National Academy of Medicine has put together a compendium of resources. And I was fortunate to be able to be part of the, to be a co-chair of the group that put this together. And we structured that in domains that really closely follow the domains of the Joy in Medicine recognition program. So there are domains in leadership and culture and practice efficiency. And then within that are resources, not only resources that come from the AMA, but resources that come from other organizations, from nursing organizations and the American Hospital Association. So that's another good source of information.
Great. So we can't thank you enough for this really fantastic presentation and discussion. And, sort of take home points that I have, if I want to summarize it in 1 minute, is burnout matters. It's a huge problem. It's costly both to individuals and to health systems. But I think more importantly, that there's a lot we can do about it if we take it seriously. And I think hopefully we can all work together for solutions.
Well, Arlene, I couldn't have said it better. So thanks so much for inviting me to join in this conversation.
Thank you very much. And thanks everyone for joining us. Enjoy the rest of your day. Okay. Thank you. Looks like everyone else is off and it's just our core group again. Thank you so much.
Thank you. Thanks for making it so easy to participate.
Fantastic. Any comments for us about a conversation, questions?
No, I appreciated the chance to review some of the chat. So that was helpful to do. And Arlene, I thought it was so helpful the way you contextualized some of our conversation with work that's happening at AHRQ. So anything you want to tell me that could make communication of some of these issues more clear to audiences like yours?
I'll just add, I think those real examples and telling stories are so critically important. And you did some of that through your slides. There were some, but any one that gets at even more detail, I think really resonate with folks, but it was great. Anything you want to add, Arlene?
Just for Christine to know, so that these are recorded, and we're like, AHRQ is not immune from people being overstretched and pulled in 7 different directions at the same time. So a lot of people do listen to this. I know there's a couple that I couldn't make, and I made sure that I listened to them afterwards. So it's going to live on. And I thought you did a great job of, really balancing like the science behind it, and that there is a whole research agenda with the humanity of it. So I thought you did I thought it was a great conversation.
Great, thanks. Well, it was my pleasure to join all of you. And I really do appreciate the work that you sponsor. I didn't say this, but I often say we have this $4 trillion industry that is balanced on this rickety scaffolding of under